This is Dr. Mostafa Foad and I am going to discuss with you fetal growth disorders. By the end of this course, the student will be able to define IUGR and fetal macrosomia, list causes of IUGR and fetal macrosomia, identify the different types of IUGR, choose the appropriate method for diagnosis of IUGR and fetal macrosomia, enumerate the hazards of IUGR and outline its management. Enumerate the hazards of fetal macrosomia and outline its management, including the management of shoulder dystocia. Identify patients with high-risk pregnancies for macrosomia and IUGR in antenatal clinics. The first abnormality is intrauterine growth restriction, which is defined using either the EFW or the AC. This curve shows the nomogram of fetal weight and gestational age. Three main categories: first the constitutionally small, second the placental insufficiency group, and at last the abnormal fetal structure group. Diagnosis depends mainly on the fetal weight determination, and we will find that 70% of cases are small for gestational age and not IUGR after thorough investigation. We have two main types, the symmetric and asymmetric IUGR, and both will be discussed in more details in the face-to-face session. We have three stages of development during embryogenesis, which are hyperplasia followed by both hyperplasia and hypertrophy, and then hypertrophy. Stage 1, which is hyperplasia and is from 4 to 20 weeks. It is characterized by rapid mitosis with increase of the DNA content. Stage 2, or hyperplasia and hypertrophy, and is between 20 to 28 weeks gestation and is characterized by increase in the cell size with declining mitosis. Stage 3, or hypertrophy, and is between 28 and 40 weeks and is characterized by rapid increase in the cell size with rapid accumulation of fat, muscle and connective tissue. 95% of fetal weight gain occurs during the last 20 weeks of pregnancy. An event disrupting the first stage will result in symmetric IUGR, while an event occurring in the second or third stage will result in asymmetric IUGR. The main event that occurs in the second or third stage is placental insufficiency. There are numerous adverse outcomes for IUGR, starting from IUFD, immediate neonatal complications as sepsis, hypoglycemia, RDS, hypothermia, meconium aspiration, hematological disorders, seizures in first 24 hours. Complications include as well impaired neurodevelopment as long-term neuromotor dysfunction, poor school performance, deficits in academic achievements. Complications might occur in adult life as obesity, diabetes mellitus, hypertension, cardiovascular disease. IUGR is classified to symmetrical growth restriction, where the fetus' entire body is proportionally small. Its incidence is 20%. Asymmetrical growth restriction, decrease in subcutaneous fat and abdominal circumference with relative sparing of head circumference and femur length. Its incidence is 80%. Causes of IUGR might maternal, as in chronic illnesses, e.g. cystic fibrosis, CHD, renal failure, hemoglobinopathies. Nutrition, e.g. anorexia nervosa and bulimia. Smoking. Alcohol. Drug abuse, e.g. cocaine, amphetamines, betel chewing. Maternal causes include also autoimmune disorders, aplabdolar, SLE. Endocrine disorders, e.g. diabetic nephropathy, hyperthyroidism, Addison's disease. Placental causes are due to abnormal placentation, fetoplacental insufficiency or uteroplacental insufficiency. Fetal causes might be due to infection as CMV, toxoplasmosis, rubella, herpes, malaria, syphilis. It might be due to chromosomal anomalies, fetal malformations and multiple pregnancy. Diagnosis depends on history, examination, and ultrasound examination including Doppler. Clinical examination includes symphysial fundal height and abdominal girth, and this will be discussed in the face-to-face session. Ultrasound criteria depends on measuring the HC, AC, and EFW, but the most important is serial ultrasound measurement. Invasive procedures can be used to rule out cases of aneuploidies and congenital infections in cases of symmetric IUGR. Doppler ultrasound is done to measure umbilical artery Doppler indices, middle cerebral artery and venous Doppler, and the value of each one will be discussed in the face-to-face session. The left side figure shows normal umbilical blood flow while the right side shows absent blood flow during diastole. The right side shows reverse diastolic blood flow in the umbilical artery. Accurate dating is the first step of management, and then the next step is determining the type of IUGR followed by exclusion of aneuploidies. Treat maternal disease. Stop substance abuse. Good nutrition. Bed rest. Maternal hyperoxygenation are all very important. Antenatal surveillance depends on serial growth scans and fetal well-being. Fetal well-being include daily fetal movement profile, NST twice weekly, BPP weekly if NST is abnormal, umbilical artery Doppler study every week. Steroids to enhance lung maturity is a cornerstone in management, and the decision of delivery will depend on the gestational age, fetal growth, and fetal well-being tests. Vaginal delivery can be only provided in tertiary centers, otherwise cesarean section is the safest option. Amnio infusion can be tried in some cases but with a low success rate. This slide shows the indications of CS in cases of IUGR, which are repetitive late decelerations, poor biophysical profile, reversed end diastolic flow umbilical artery, abnormal venous Doppler, and blood gases showing acidosis on chordocentesis. Actually, no effective screening test is available, and as a prophylaxis only low-dose aspirin might be effective in high-risk population. Notching in uterine artery Doppler might help in identifying high-risk cases. The second abnormality in fetal growth is macrosomia or large baby, which is the birth weight is 90th percentile for gestational age. The causes of macrosomia might be maternal or fetal, as in genetic and constitutional. Maternal obesity. Maternal diabetes mellitus. Multiparity. Post-term pregnancy. Previous macrosomic baby. Hydrops fetalis. Congenital malformation. And again, diagnosis depends on clinical examination and ultrasound. This slide shows the complications of macrosomia, which is mainly due to difficult delivery and includes obstructed labor and shoulder dystocia. Increased rate of operative and instrumental delivery. Maternal birth canal injuries including uterine rupture. Atonic and traumatic postpartum hemorrhage. Neonatal birth trauma. Shoulder dystocia is the most serious complication of macrosomia and is the nightmare of obstetrics. It can be defined as head-to-body delivery time exceeding 60 seconds, simply it means failure of the shoulders to traverse the pelvis after delivery of the head. The best of management of shoulder dystocia is by prevention and proper identification for the need of CS. If the estimated fetal weight is 4,500 gm in the non-diabetic or greater than 4,000 gm in the diabetic patient, delivery by cesarean section is safer. The turtle sign is the first sign of shoulder dystocia, and once it is seen you should call for help. Call for help is the first step, followed by emptying the bladder, generous episiotomy, and MC Roberts maneuver. This slide shows the maneuvers used in managing shoulder dystocia, and each one will be discussed in details in the face-to-face session. This slide shows the Roberts maneuver and will be discussed in details in the face-to-face session. Suprapubic pressure and will be discussed in the face-to-face session. Wood's corkscrew maneuver and will be discussed in the face-to-face session. Delivery of the posterior arm and will be discussed in the face-to-face session. Symphysiotomy, which is actually an obsolete procedure due to excessive complications that can happen. Thank you.